please.
So this is the lateral side of knee joint. We see in the anatomy here, this is the girdous tubercle, and this is the patella. And here we have iliotibial band, and here biceps femoris. And this is the muscle, and this is the ligament. And this is rectus femoris, and patellar tendon is here. As we see, this is the lateral collateral ligament here. And this is the biceps femoris. The distal iliotibial band in its long axis view, as we see here, and the sonoanatomy, this is the girdous tubercle, as we see here, and this is the femur here. If we put the probe just between femur, we palpate femur and we palpate girdous tubercle, and just we put the probe between them, we can see this nice picture. This is the ligament, iliotibial band, sorry, hyperequifibrillary structure, as we see here, between the girdous tubercle and femur. And this is the distal iliotibial band in the transverse plane. This is the lateral femoral condyle. Here we see lateral retinaculum, and as it's inserted into the patella. This is the lateral condyle, this is the patella, and this is the lateral retinaculum, and this is the insertion to the patella. Here I did panoramic view to the lateral knee structure in the transverse plane. We see whole structure, so this is advantage for ultrasound over MRI and CT, as we cannot see panoramic view. This is the fibular collateral ligament in short axis, and this is the deep superficial layer of biceps tendon in short axis. And here I will show video how we do ultrasound scanning for lateral knee joint. Here, this is a girdous tubercle, and here, this is the iliotibial band we see here. And so here I repeat just the anatomy, which I said you. So we examine lateral collateral ligament and iliotibial band. Here I just show I put the probe in a transverse view between to show the lateral collateral ligament between, and this is the girdous tubercle, and this is the femur here, and this is the iliotibial band, and here lateral meniscus. It's a hyperequifibrillary structure, triangular shape, as we see here, and we should examine whole band at its common, and as we know, iliotibial band syndrome. And this is the position for lateral examination of knee joint. As we see here, we go from medially to laterally in transverse view to examine whole lateral collateral ligament and lateral meniscus. So here, and also we see here the lateral collateral ligament. This is the lateral collateral ligament, hyperequifibrillary structure. We should examine in short axis view and in long axis view. This is the popliteal tendon. So the structures we have to show a lateral collateral ligament and iliotibial band, lateral meniscus. This is what we have to show in the lateral view. And when we move to posterior compartment, we have to ask the patient prone position to show the posterior compartment of knee joint. As you see here, iliotibial band coming from lateral posterior and go lateral anterior, and this gracilis, semitendinous, and semimembranous. It's go down to join the mesenterim versa, and we have here gastrocnemius medial and lateral head of gastrocnemius. Also, we have to examine this structure in the posterior view. This is the biceps femoris. This is the position of the transducer for the distal semimembranous and semitendinous tendon in the short axis view. This is, we see semimembranous, and this is medial condyle, and this is sartorius muscle, and we see here also medial head of gastrocnemius muscle. So we have here, we show the position here, sono anatomy for the prop position as we see here, and this is the sono anatomy for the position here. This is the cartilage over the medial condyle. And here we see vein, as we see, this is the artery, but always it's guided us, but sometimes when there is anisotrope or inappropriate prop position, it should be in sono anatomy red color, and the vein should be blue color. And this is biceps femoris here, and this is femur. This is femur and biceps femoris. The popliteus tendon, the coronal view as we see in short axis view. This is femur condyle and tibia. This is the popliteal tendon. As we see here, this is in long axis view, the popliteal tendon and ligaments, always hyperechoic fibrillar structure. If there is any anisotropy or hypoechoic, we have something wrong. This is the femur condyle. This is the transverse view as we see for semimembranous tendon and semimembranous muscle. This is the tendon and this is the muscle. Here, if we want to examine Baker cyst where fluid could be accumulated, it's common that the patient can come to the clinic or to complaints of posterior knee joint pain, and the fluid could be accumulated here in the Baker cyst. This is the Baker cyst like us, like should be here. So this is in normal. In abnormal, we show hypoechoic, anechoic structure here. This is the middle head of gastrocnemius muscle, and this is the tibia. This is a long axis view, semimembranous tendon and semimembranous muscle, and this is the tibia. This is panoramic view for proximal gastrocnemius muscle. This is the medial head of gastrocnemius and lateral head from gastrocnemius muscle. This is soleus, and this is the medial side, and this is the lateral side. We do panoramic view to see whole structure. This is the popliteal fossa as we see here. The vessels here, let's see, and this is the medial head of gastrocnemius muscle. Sometimes we turn on the Doppler here to see if there is, to see the vessels. This is the artery, as we said, red, orange, and this is the blue color for vein. This anatomy for popliteus muscle in the transverse oblique plane long axis view. And this is the posterior lateral meniscus and the sagittal plane. This is the cartilage, and this is the lateral meniscus, and this is tibia, and here femur. And now we move to posterior cruciate ligament, PCL. This is the probe position we should do for PCL and coronal oblique position for PCL. PCL also intra-articular structure. Sometimes it's challenging to see. So this is the sonoanatomy for PCL. As we see, we see just part of posterior cruciate ligament, and the hidden part is going inside the joint. And we see here the MRI, and this is the MRI for normal PCL, as we see here, and here the sonoanatomy for normal posterior cruciate ligament. And this is the posterior cruciate ligament in the sagittal plane, long axis view. It's a hyperechoic fibrillar structure, as we see here. And here, the ligaments, there is some anisotropy, and this is the tibia. This is the posterior view of, for anterior cruciate ligament. In short axis view, this is the lateral femoral condyle, this is the medial femoral condyle, and this is the medial head of gastrocnemius muscle, and this is the artery. Here, how we do posterior compartment ultrasound scanning knee joint. As we see here, we should examine the gastrocnemius muscle, medial and lateral gastrocnemius, and we should examine the posterior cruciate ligaments. Middle and lateral here. We should examine carefully, and I go here up and to the joint, toward the joint. And this is the semimembranous tendon and the muscle, and the here medial head of gastrocnemius muscle. And here, trying to explore the whole structure in the posterior compartment. So manipulate. This is the advantage of ultrasound, so you can manipulate and to see the structure, just to avoid anisotropy. Anisotropy, which means black, so you don't see the right structure properly. And here in longitudinal view, we examine, so just we turn and we see here in longitudinal view, trying to see the posterior anterior cruciate ligament and the meniscus from posterior view. This is the posterior horn of medial cancer. This is the semimembranous muscle and tendon. So always we have to be slowly scan the structures and in longitudinal short axis view. So in summary for today's lecture, the knee is susceptible to a variety of traumatic and non-traumatic injuries due to the relatively superficial location of the knee and its surrounding soft tissue. Many of these pathologic conditions can be diagnosed or assessed using ultrasound. The advantages of ultrasound include portability, absence of radiation, and dynamic imaging capability. Incomplete evaluation of intra-articular structure is an inherent limitation of ultrasound, and other advanced imaging modalities may be required for complete evaluation. An understanding of the anatomy of the knee joint, and it's very important, and surrounding structure is essential for interpreting ultrasound image. A brief outline of the structures assist as part of the fundamental knee examination is provided above. High-frequency linear array transducer is prepared for evaluation of the superficial structure of knee, and sometimes we have to use the low-frequency curvilinear array transducer may be required for adequate imaging of the deeper structure or in larger patients, obese patients. Sonographic evaluation of the knee joints organized into a 4-quadrant as other joints, shoulder, ankle, all joints we have to divide to 4 quadrants, anterior, medial, lateral, and posterior. As we see here, the ultrasound makes impossible possible as widely we increasing using the ultrasound. This picture is taken by my friend in Dubai, Dr. Ammar Salti. He is a president of Galpin School and working in Cleveland Clinic, Abu Dhabi. And this picture is for Tom Cruise when he came to Dubai to do a film as an act film, and he fall down and he has like chest pain. He cannot continue the film. It was its name Impossible Mission. So they asked my friend Dr. Ammar to do for him ultrasound injection, intercostal block, and impossible become possible. So he continued the film. And this picture is shared by our dean, Svetlana Krasnikova. It's a nice picture. And this is our lovely university. I hope soon I can visit Ukraine and our university. This is my Facebook profile page, and this is my mobile number, WhatsApp number, email, and anyone can ask me or send me message for any details, questions, and I hope we can do soon workshop on site in Kharkiv in our university. We will arrange for that. We will teach and learn how to do ultrasound scanning on site, hands-on for all joints, for peripheral nerves, and thank you for your attention.
Okay, Abdullah.